In this video, we'll discuss behavioral therapy. In behavior therapy, the principles of learning are applied to change undesirable behaviors. It's based on the belief that dysfunctional behaviors can be changed by teaching clients more constructive behaviors. So the goal is to change dysfunctional behaviors by teaching these more constructive behaviors, and this occurs through conditioning. Counter-conditioning is a classical conditioning technique where clients learn a new response to a stimulus that has previously elicited an undesirable response. It includes both aversive therapy and exposure therapy, and we'll discuss both of these in a little bit more detail. So aversive conditioning is going to use an unpleasant stimulus to stop an undesirable behavior. It's often used to eliminate addictive behaviors. In aversive conditioning, the client's going to be repeatedly exposed to something unpleasant, such as maybe a mild electric shock or a bad taste, while they engage in behavior that they want to change. Over time, the client's going to learn to associate the unpleasant stimulus with the unwanted behavior. So an example of this is antabuse. So antabuse is a drug that can be taken and it causes really negative effects like vomiting, flushed faces, feeling really hot when you combine it with alcohol. And it has to do with the fact that it blocks the breakdown of acetaldehyde, and so that builds up in the individual. And it has been used to effectively treat alcoholism in some individuals. And it's only used really in severe cases. So the idea is that then if the individual who's an alcoholic, they're taking this antabuse and they don't plan out when they're going to have their next binge. It's just all of a sudden they start to drink. Then now they're on this medication, they ingest the alcohol, they have these very horrific effects, sometimes even requiring, or most times requiring hospitalization. And so that then instead of pairing that alcohol with the sense of relief or forgetting or whatever it is that alcohol gives them, they then associate it with these negative aversive consequences. I actually had a friend whose sister was treated with antabuse for a while. And my friend said that she called her a couple times. One time she's a recovering alcoholic and called her once and said, "Sorry, Amy, here's where I am. I'm going to drink. I'll probably need to go to the hospital." And so my friend said that it was just horrific, like the side effects, the vomiting, all of the effects that she had, but she wanted to drink. And so her need to drink overwhelmed the negative consequences. So, but her sister has a lot of kind of really untreatable extreme conditions. And this is just a diagram showing you how that acetaldehyde builds up when that anti-abuse prevents the breakdown of that from the alcohol. Exposure therapy seeks to change the response to a conditioned stimulus. It's typically used to treat fears and anxiety, perhaps phobias. It involves repeated exposure to the object or situation that causes the problem, with the idea that the client will eventually get used to it. So this here is Mary Cover-Jones, and she developed the first type of exposure therapy. So think back to classical conditioning in the learning chapter, and remember little Albert, he was taught to fear furry white objects, but Watson and Rayner really didn't do anything to remove that fear, according to the stories that we hear. Jones was sitting through a seminar that she heard by Watson and Rayner when she heard about little Albert, and she wondered if she could reverse that fear process through what we now call today counter-conditioning. So in a series of experiments with little Peter at Columbia University, Jones aimed to replace Peter's fear of white rabbits with a conditioned response of relaxation. Peter already had the conditioned fear of the white rabbit, and so something that's an opposing response is the relaxation or the happiness that milk and cookies gave little Peter. The natural stimulus was milk and cookies, the natural response was relaxation or happiness. So Jones paired that stimulus that elicited an opposing response, the snack, the milk and cookies, with the rabbit. So the US was paired with the CS, and the unconditional response of pleasure, relaxation occurred. So over time, pairing these two things led to the white rabbit no longer eliciting the fear response, but eliciting that relaxation or the happiness. So she started with the rabbit in a cage on the other side of the room, and then over several days, she gradually moved it closer while Peter ate his snack. After 2 months, Peter was actually able to pet the white rabbit while eating his snack. So in 1958, Joseph Wolf redefined or refined Jones's techniques and developed a version of exposure therapy that's used today often in therapy, which is called systematic desensitization. So this is a type of exposure therapy wherein a calm and pleasant state is gradually associated with increasing levels of anxiety-inducing stimuli. The fear and the relaxation are incompatible. So if a client can relax around a fear-inducing stimuli, the unwanted fear response will eventually be eliminated. The client is taught progressive relaxation techniques, how to relax each muscle group so that they achieve a relaxed and really comfortable state of mind. Progressive relaxation is used while the client imagines anxiety-inducing situations. So over time, the progressive relaxation helps the client be able to become desensitized to the anxiety-inducing stimuli. So you're becoming desensitized to what originally provoked the anxiety. Behavior therapy also can use operant conditioning techniques. So operant conditioning techniques used in behavioral therapy are based on the principle that behaviors become extinguished when they're not reinforced. Applied behavioral analysis is an operant conditioning technique that's designed to reinforce positive behaviors and punish unwanted behaviors. It's commonly used to help children with autism. When working with children, of course, child-specific reinforcers are going to be used: stickers, praise, candy, and they're used to reward and motivate autistic children when they demonstrate desired behaviors. If you remember back to chapter 2 when we discussed research methods, I used an example of ABA to discuss case studies. Sam was unable to eat because he couldn't tolerate textures, and over the course of 2 years, applied behavioral analysis was used to help him have a better diet. Now, while some therapists might use punishment like a timeout to discourage maybe an undesirable behavior, a true behaviorist doesn't believe in punishments. And I actually have a neighbor whose daughter's applied behavioral analysis. She has a master's in applied behavior analysis. And so when her sister's first child was like 18 months, she was determined she was going to use ABA to potty train that child, maybe even 16 months old. And it should in theory work. But it was my neighbor and her 2 daughters, adult daughters, working together, and I think the 3 of them together probably weren't the best mix. If it would have just been one of them, perhaps it would work. So they canned the idea after a couple of days and decided to come back to it when she was a little bit older. But it was funny hearing the stories about how they were trying to reinforce this, and they weren't agreeing on how to reinforce things and what to reinforce and all this kind of stuff. So, but in theory, these techniques could be used to teach potty training in a very quick manner.